Hello everyone, I'm Joe Iannotti. I'm Professor and Chair of Orthopedic and Rheumatology Institute at the Cleveland Clinic. I'd like to welcome you to Transparency, Consumerism, and Value in Orthopedics. It's a three-part series on delivery of market-informed, value-based care, jointly presented by the Cleveland Clinic and Castlight Health. So now it's my pleasure to introduce you to the distinguished faculty that I am privileged to work with. Dr. Joe Zuckerman, Chairman of the Department of Orthopedic Surgery at the Hospital for Joint Diseases, New York University Langone Medical Center. Dr. James Robinson, who is the Leonard D. Schaefer Professor of Health Economics, University of California, Berkeley. And Dr. Kevin Bozick, the William R. Murray Professor and Vice Chairman of Orthopedic Surgery, University of California, San Francisco. Okay, gentlemen, let's get started. A lot of changes in healthcare, particularly over the last few years. Some of that's related to transparency and transparency in data. Jamie, how do you define transparency? What does that mean, and what does that mean in particular to orthopedic surgeons?
One of the most important trends in healthcare right now is the rise in transparency. By transparency, by which we mean consumers and patients seeking out and being able to access more information than in the past, information about the quality of care, information about the price of care, and bringing those questions often to their doctors or to their other healthcare providers.
So what does that mean, Kevin, in terms of how patients, consumers, then look at their care provider? Do they look at the doctor, the hospital, any differently today than they did 5 years ago?
I think patients are seeking information about where to seek elective care, which is particularly relevant to orthopedic surgery. Most importantly, they're looking for information about quality, and quality to patients includes things like doctor communication skills, doctor-patient relationship, but also outcomes. They're also increasingly interested, as Jamie Robinson said, in cost information, but it's cost information that's relevant to them. What is their out-of-pocket cost for this care? And so that information is a little bit easier to come by, although it's not particularly easy, but the quality information is particularly difficult for them to find.
So relevant to insurance companies or payers or employers for that matter, and certainly in New York, I think there's always been a sense of consumerism in every sector, maybe not always healthcare, but in other areas. So how have insurance companies or employers looked at this issue of transparency of reported data, be it the quality side or the cost side? Have they used it as a driver to move their patients or their employees in one facility or another?
Insurers are being much more selective about who they include in their network in terms of institutions, to a lesser extent physicians, but physicians as well. And they're continually now presenting the institutions with, this is your data, this is how many readmissions you have, this is your length of stay, and going forward, they want to change the curve on these things. And the way they've been doing this is in a cost sharing or an approach that basically says, if you do well, all right, we'll share in that. If you don't do well, there's risk involved in it for you. And I think this is the move. I just want to address something that both Jim and Kevin said about the patient's role in this when they've got some skin in the game, right? And that has to do first and foremost with how much out-of-pocket expense it's going to be. And that transparency is important, right? Because they want to know how much it's going to cost them. They're much less informed or interested in the outcome side of the equation, and that's an education that's going to have to take place for the consumers of healthcare in this country.
So I agree with what Joe Zuckerman said about patients being interested in cost information, and I think the reason for that in orthopedics is because of the dearth of quality information. We did a study asking patients specifically what information they were seeking, and as Joe said, number one on that list was physician manner or communication skills. But number two, and statistically insignificant, was physician quality, meaning specifically outcomes. And then when we went to the next question, in our survey, patients said that they were very interested in information differentiating surgeons based on quality. They knew that there were differences among surgeons based on quality, but they did not know where to get that information. And it's very different from, say, cardiothoracic surgery, where there is very detailed information on consumer reports based on the Society for Thoracic Surgery database, which differentiates providers based on quality. So I agree with Joe that they're less interested or less able to find information about quality in orthopedics until we put that information forward.
Right, and I think, clearly there are quality metrics that are being reported for us, and I'm not sure any orthopedic surgeon necessarily buys into the fact that those are the true quality metrics that we want to be judged by. We often want to know how our patients are doing. Our patients see us for pain relief, they see us for improvement of function, and nobody's really measuring that on our behalf, which really means that it's our obligation as surgeons or facilities to measure patient-reported outcomes and then report that.
And I'll ditto on that. I'll just say, from the point of view of the insurers and the employers, either you do quality measurement or we'll do it to you.
Right, and if you debate that point, then shame on you, because you're not going to likely win that discussion. I mean, you either have to present your data in a fair, honest way, or somebody's going to report it on your behalf. I did want to get back to Jamie's comment about CalPERS. First, I think it's important that we define what CalPERS is. And they did something a couple of years ago with reference-based pricing, which really changed that market substantially. And there's been some good data to support what happens when you have cost transparency.
The CalPERS is the California Public Employee Retirement System. It's essentially public employees in state of California, municipalities, et cetera, in California. About over 1 million people get their insurance through CalPERS. And CalPERS realized that it was paying between $20,000 and $100,000 for a total knee and total hip replacement in different hospitals in the state, without any evidence that there was a correlation with quality of any of this. Mm-hmm. And so they instituted what's called a reference pricing or reference-based benefit design, which said that they would pay up to $30,000. And then the patient would have to pay anything above $30,000. Then they had a transparency campaign to tell the patients which hospitals charged less, and they also negotiated with those hospitals to make sure there was a lot of brand name hospitals that came in under $30,000. The Hoag Hospital and UC San Francisco. There was a lot of very prominent hospitals that were affordable. And what happened was, and we did a study of this on behalf of CalPERS, was that patients do move. They move. If they're spending their own money, they will move. There was a significant shift towards the lower-priced hospitals, and some of the higher-priced hospitals also significantly reduced their prices. We're now doing follow-up studies looking at ambulatory procedures, including arthroscopy, and which CalPERS is also creating reference-based benefits for. And again, we see patients are really moving. And the facilities are really responding.
You guys did, with reference pricing, the first half of the equation. You identified the hospitals that were going to meet your cost criteria. But how does CalPERS tell their patients, these hospitals are not only not going to cost you any money, but you can anticipate with a significant degree of certainty a successful outcome? Right. So how did that get into the equation?
That's the outcome piece of the equation that CalPERS would love to have, and CalPERS has approached us, as I chair the California Joint Replacement Registry, and said, could you give us that quality piece of the equation? Now, for obvious reasons, providers are concerned about transparency and quality because of concerns about risk adjustment and sample size and the outcomes. But that concern about being transparent about outcomes has led to competition purely based on cost. And I think that we as a profession want to shift that competition to value-based competition, not cost-based competition. In order to do that, we have to get comfortable with being transparent about our outcomes.
Yeah, I think, if we look back at the clinic, Cleveland Clinic, and what we've done, we realized that several years ago. And we went through it as an institution an effort to try to publicly report our outcomes. And we published whatever we had, good or bad. And I think, not only did the public appreciate that, but I think it raised the bar for everybody at the Cleveland Clinic. To say, okay, this is what we did last year, we have a charge to do better next year. And I think over time, that publication, which has become pretty popular, and I know a number of orthopedic groups around the country have since followed that. I know NYU has now, public reporting of some of its outcomes. I think that's going to probably trend towards more of a value-based report rather than just purely a outcomes-based report.
And just in terms of CalPERS, what they're doing, they are financing follow-up quality studies. Kevin and I are working on this. He's part of doing the quality part, I do the cost part, looking at what were the outcomes differences, given that patients moved. They moved across hospitals, they moved from hospital-based to ambulatory facilities for their arthroscopies. What were the outcomes to the extent that we can measure that? And the better that we can do that, then make it publicly available so for the next round, because then the employers, a lot of them are going to move towards what I would call a narrow network strategy. Okay, instead of saying you can go anywhere you want, but you pay more if you go over here, they'll say, well, no, you're not going there at all. We're going to have, these are the facilities, and they've passed our quality metrics and our cost metrics, and this is it. This is, call them Center of Excellence, call them what you will, but this is it.
Right. So the Cleveland Clinic published their outcomes report, right? We've done the same, right? We've done it voluntarily. However, it's the involuntary reporting of outcomes. So in New York State, every hospital has their infection rate after total hip replacement published. And they try and stratify it based upon some risk scenario, higher acuity patients, lower acuity, but it's right out there in the public domain. But that's only one reporting measure. Now, if you go to various CMS websites for Hospital Compare, you're going to look at one hospital versus the next. So there is data out there. The question is it helpful data? Is it useful data? And is the public using it? I don't think they've quite caught on to that. So as a profession, we have to also buy into this. Now, but just reporting of data, is not without its shortcomings as well. All right, if I have a higher risk population, my patients are going to have a higher incidence of complications afterwards. But if the guy in another hospital's not doing those cases, but we are, you have to account for that too, and it's hard to do it, but it needs to be out there.
Yeah, go ahead.
So I completely want to agree with what Joe said, that the profession has to get behind this. The reason why patients don't put a lot of stock in this information is because we have not endorsed it. As soon as the profession gets behind it and says this is valid information, this is useful information, patients will follow. I would say physicians from the literature, the physician community is the most trusted source of information, followed closely by groups like Consumer Reports.
There's no question that public transparency of both outcomes and cost is here to stay. It's not going to go away. And it's going to go from facilities to individual providers. So the only way as an orthopedic surgeon, I think, that you are able to manage this is you've got to get deep into the weeds. You've got to understand your own data first. You've got to understand your own methodology first. And you've got to be transparent about it. When we went through our process here at the clinic, obviously we report service line. But you can't get to service line until you know every individual doctor's outcome and cost. The first thing we did was unblinded transparency to everybody practicing that specialty within that group. And what do you think the first thing they do is? They say is the data is flawed.
Oh, right.
Okay, which is fine. That's perfectly fine. Because now you have an engaged physician. Now you have somebody who's saying, I'm going to roll up my sleeves with you and make sure that the data is valid. And you have to, as a leader, say, well, if it's not valid, we're going to change the model so that it becomes valid. But as soon as everybody then agrees that the data is valid, then everybody moves to try to make it better, either on the quality side or the cost side. So, I think the process is a healthy one. Unfortunately, it cannot be dictated by an outside agency that doesn't necessarily understand the product line, understand risk stratification, but is just interested in making it publicly transparent. So again, it's an ownership issue, and it's a matter of orthopedic surgeons to say, the train has left the station, I might as well, get on board and move with it.
So I think you're right on target. You have to get physician buy-in. Now, and institutions like where we work, we have some control over that, some ability to do that. At NYU and the Hospital for Joint Disease, we do a physician resource utilization and quality analysis. And you could say that, how do we measure quality? Well, it's VTE, readmissions, infections, and such. And we put every one of our arthroplasty surgeons in one of the quadrants, right? High cost, low quality up here, high cost, good, high quality here. But we track over every 6 months. We're trying to move the people from this upper end of the curve down to this corner of the equation, which is high quality, low cost, trying to move everybody that direction. Everybody gets their own individual data related to this. And right, it gets some buy-in. There's complaints about it. What do you mean? That wasn't an infection, all right? That was just something superficial, the usual stuff, right? But you have to get their buy-in. If you don't do that, then you're never going to move anything. So, however, it becomes from there, right, from doing it within an institution, right, it's not a whole lot of steps beyond that for your insurance company to provide the information that's physician specific, or to put it up, in a statewide database as you've talked about. So I think that we're there. I usually predict we're closer than we really are. It's still a few years away at least, but it's certainly moving in that direction. And there will be legal challenges to getting this data out there, I'm certain.
And I think it's also important to recognize that there are different uses of the information. So there's an accountability piece of using this information, which is public reporting, transparency, and some of that flows to different payment models. But there's also a performance improvement aspect of this, and you've alluded to that, Joe, at the Cleveland Clinic, that certainly a certain part of us wants to understand what our performance is so that we can improve it. I use the analogy, if I play golf, I'd like to be able to keep my score so I know how I'm doing and I can get better. I'm not keeping my score to show all you guys that I'm a better golfer than you. I'm doing it for my own internal purposes so that I can get better at what I do. So the accountability part of it gets the hair up on the back of our necks and gets us all defensive. Well, the numbers aren't right, it's not risk adjusted, but there's a performance improvement part of this that once you start sharing this kind of data with physicians, they want that data. They want to see how am I doing relative to my peers and how do I improve? And that's the conversation and the culture that you want to create within an organization.
Sure, and I think any of us who have given this even a modest amount of thought have realized that you really can't move the value equation, either on the cost side or the quality side, without better integrated relationships between the provider and the facility, between the provider and the facility. And in fact, if you say, well, where is the bulk of orthopedic practice? It's not at UCSF or at the Cleveland Clinic or at NYU. It's in private practice. It's in smaller, large groups that have multiple associations with various hospitals. So if you say, well, how do you really move the bar in terms of quality? Because quality is not just what you did in the operating room. It's the entire care process from the time the patient gets admitted to the time the patient gets discharged. So the only way you're going to move that bar is for orthopedic surgeons to realize that they have to have ownership of the entire process, from wheels in to wheels out, and they've got to partner with their facilities. And so that whole issue of integration, maybe you can address that.
Sure, I think and this follows up right up, which I thought, by the way, Kevin, was really well put on the performance improvement side of this whole story, is that the reality is, and I'll go back to the cost side, being the economist, hospitals and the surgeons, once their price data and cost data is more visible to the consumer and the consumer has a more cost-sharing responsibility, they are going to migrate towards more lower-priced facilities, and the response of the surgeons needs to be, well, how can we, with our hospital, get our prices down? And the reality is that surgeons have a lot of discretion in that, in terms of their choice of implant, your referral to MRI, the length of stay the patient's in the hospital, whether it's done in an ambulatory or a hospital-based center. There's a lot of choice there, and the doctors are going to have to realize, or they should realize, that they are the stewards of the money of society in this. In some sense, you guys are spending our money by your choices, and we want you to spend it wisely, please.
Right.
I think what Dr. Iannotti said is very important, that the vast majority of orthopedic care in this country is provided not by people where I work or you work or such in large institutions. It's provided by people in small and large practices working at 1, 2, or 3 different hospitals. And it's getting those members of orthopedic surgery, members of the medical profession, involved and engaged in this is more of a challenge. The physicians out there in the community, the orthopedic surgeons who work in institutions that don't have the infrastructure we do, but need to get the infrastructure, now they need to be able to look at their institutions and say, okay, how am I going to fulfill these quality requirements? How am I going to address these reporting requirements with the institutions where I work? And they may find out that of the 3 hospitals where they operate, only one of them can really deliver the care that's going to be needed. They're going to have some alignment with that institution to be able to pull this off. But ultimately, most physicians and orthopedic surgeons will ask that question, what's in it for me? Now you can say that what's in it for you is insurance companies aren't going to send patients to you if you don't fulfill certain criteria. That's probably further down the line. So there has to be some kind of a relationship that develops between institutions and the rank and file of practicing orthopedic surgeons that makes this not only doable but attractive from both sides. And then you get into things like gain sharing, opportunities like that, and that needs to be explored. But mostly you have to work hard to get the vast majority of orthopedic surgeons engaged in this process.
Yeah. You know, and the reality is that the orthopedic surgeon has as much, if not more, to gain. Because if you look at the total spend for an episode of care, the majority of the spend is on the facility side. And as you said earlier, they are the decision makers in how those resources are spent. So if you talk about this issue of gain sharing and say, what's in it for me, partnership, employment model, alignment, whatever word you want to use, there has to be transparency of data between the hospital and the doc, and there has to be a genuine partnership, as you said, where you say, listen, we both have to float this boat at a much higher level in terms of saying, how do we cut out cost, improve quality to be competitive in the market? Because there are clearly insurance companies that are going to use this data to direct where their clients, where their customers go. And maybe you can address that. What are the insurance companies doing with this whole consumerism movement?
I think that the insurers, and with them the large employers, see orthopedic surgery as a major area which they want to get involved in. Big ticket item, and there's a lot of discretion in that. And as I think about we want to call their strategies, I can think of 4 major things that they're doing. First of all, they are increasing the extent to which the consumer has to pay out of pocket, either through a deductible or reference pricing or other things. So now the patient really is more concerned about the price of care. That's number 1. Number 2, in some cases they are going for a narrow network strategy, by which I mean they are trying to direct or channel all of their members to a smaller number of facilities that are willing to come in and take accountability for orthopedic surgery, for bundle pricing, quality measurement, patient experience monitoring, all in. And so that, and then they'll just cut some hospitals out altogether. The third thing that they're working on is transparency, to get more, especially of price data, but quality data to the extent possible, into the hands of the consumer. There's new mobile technologies that make this easier than it was just a few years ago. And a lot of the health plans are investing a lot of resources in that. And fourth, they are concerned about the appropriateness of the procedures, and when they think about appropriateness, they're going to end up very quickly advocating shared decision making. So they're big boosters of shared decision making programs, and I know that Kevin and others have worked on that a lot.
Yeah, and I think to combine what both Jamie and Joe just said, I think that aligning incentives around value is the key to sustainability of these initiatives. So I would say there's an inherent mistrust between the physician community and most of the hospitals where they practice, between the provider community, both hospitals and physicians, and the payers, and overcoming that mistrust and through alignment, and that includes better data sharing, being more transparent about the data, agreeing on which data is actually important to use, and then having people incentivized to provide better quality care at a lower cost. Many of the partnerships that I see forming between hospitals and doctors, for instance, are around market share or around surgeons wanting to be taken care of and get out from under their overhead, hospitals wanting to buy up a practice to lock up a certain number of ancillary services, et cetera, et cetera. Those are not sustainable partnerships, in my opinion. If the partnership is around By combining forces, we're going to be able to provide better care at a lower cost, including the partnership that we have with the payer. I think that's a more sustainable partnership.
What other technologies, you mentioned these handheld mobile devices that presumably the patient can use to shop for their MRI. I know we've seen that here in the Cleveland area that, depending upon your carrier, you may have information to say that a shoulder MRI at this facility is $300 and 3 blocks down the road it's $1,000. Obviously that's resulted in price pressures for the higher end facility to decrease their costs. But what other technologies are out there that help lend itself to this whole consumerism movement?
In terms of price transparency,
yeah.
The data ultimately derive from paid claims that the insurers and the self-insured employers are paying. They have data warehouses, they collect that data, and then they are able to say what is the average price that they're paying at different facilities. And then they make these data available. You can get it through your laptop, you can get it on your iPad, you can get it on your cell phone. The patients care to the extent that they are now facing more cost sharing, but otherwise they wouldn't care, of course. And it's a common thing. Some of the health plans do it themselves. Some of them contract. There's data vendors out there that are good at this. But the technology is improving. The underlying quality of the data is improving. And then, of course, the next step is to combine that with available measures of quality. I just want to emphasize the insurers and the employers love quality data. So if there's quality data, they will put it out there. They're not trying to hide it. They want to put price data and quality data, but the quality data, it's got to come from somewhere.
So the requirement of institutions and physicians to utilize electronic medical records, as difficult as it has been for some, I think is a major step forward in getting the data. Right, you don't really, particularly if you have, there are a few large electronic medical records systems that are out there, but now institutions can't say we don't have the data, and the requirement of physicians to utilize it, or having that incorporated into whatever takes place at the hospital, provides data that you didn't have before. Right? And then if you can, as New York State, where they have statewide databases, if you start extracting that information, you find out that, patient Smith, who had surgery in hospital A, was readmitted to hospital B. Right, and you can accumulate that data and really have a much more robust data set that's available. Now, having an electronic medical record for an individual single practicing orthopedic surgeon, is a challenge because of the expense involved. But the government has made that a priority, and in fact, a mandate, I would say.
And I agree that with both of you that the data sources are getting better. We still, as a profession, though, have not defined which are the elements in those data sources that matter in terms of quality, and that's what the patients want to hear from us. The patients want to know, how are your outcomes differentiated from others? And outcomes, I want to emphasize this point, are not just complications, right? So patients are not coming to see us to avoid a complication. Ultimately, they're coming to see us to try to improve their quality of life and function and reduce their pain. We need to be measuring that in a systematic way on every single patient, risk adjusting that and putting that forward. And at AEOS, we're trying to develop a strategy to get all of the specialties together to define which patient-reported outcomes are important to measure, and then figure out how to measure them and incorporate that into the electronic health record.
I personally want to thank everyone for attending the webinar. I hope this has been useful and informative session, and I encourage everybody to spend the extra time to watch the second and third webinars of this series.